fast. There we go. So now in part 2, we are going to start looking at some of the practicalities of what happens when your patient comes into the consulting room. So there's a certain art about how do we create an environment very quickly where our patient can feel safe enough to be able to start sharing with us what's actually going on with them, because that's what we want to do. We want to find out what's actually going on so that we can address the right issues. So first, just a little bit of a general rule is to look at how we make our patients feel safe generally. So I've already explained this picture of chimp, and I'm going to give a few tips on what kind of things helps to increase the safety of our patients. And so my next favorite book, and you're going to see I'm going to bring quite a few things out of this particular book, is called The Coaching Habit. And it's actually written for life coaches, so the kind of people who coach people. And he works particularly through 7 brilliant questions. And I'm going to cover some of those questions here. But it's a way of actually taking somebody through a process. If you're a teacher or a mentor or a coach, I think even for doctors and therapists, a very useful book, very, very practical. And so he talks also about this, how do we create the safety level within your relationship with your patient? And he calls it TERA. It stands for different things. And we're going to go through the 4 things now. So the first thing is tribe. So remember, the chimp part of ourselves, this limbic system, needs to feel safe. And if you think of a chimp, it likes to be in a troop. It likes to feel, where does it belong? So the one thing that's already in the back of the mind of your patient is, are you with me or are you against me? So are we on the same side, or am I here to be told what to do by the great expert? The second level is expectations. So when you enter in a consultation, or even at the end of your consultation, the more you're unsure about what's going to happen, the less safe you feel. The more you know this is going to happen, even if it's not nice, the more your safety level can go up. So often explaining to our patients what is going to happen. We're going to have a consultation now. I need to admit to you, it's going to take about an hour for us to fill in all the paperwork. We're going to take some blood tests. So to start giving them a little bit of an idea of what's going to happen already increases the safety level as well. R stands for rank and has to do with power. And it has a little bit to do with the power in that relationship. So in a doctor-centered consultation, the patient will have an experience that the doctor is more important in that consultation than they are. And in a patient-centered consultation, the patient needs to experience that they are more important than the doctor, and the doctor is just there to serve them. When I mean important here, I'm not talking about the general ranking of people in the world and importance, or in terms of degrees or qualifications. I'm talking about whose agenda matters in that meeting. And in our patient-centered approach, it's all about the patient's agenda. And as a doctor, I'm just there to serve it. The more the patient feels that it's their agenda that matter, the safer they will feel. And lastly, autonomy, which is sort of linked to that thing of how much their agenda matters, is if they know that they will have a choice and a say in what is going to happen, that they're allowed to contribute to what is going to happen. So there's different ways of thinking about TERA. You will notice a lot of the things we're going to be teaching automatically will do this. And one can also consciously do this. So if you're ever going to have, what's lovely about these skills is you don't only use them on patients. If you're going to have a difficult conversation with your teenager or your spouse or an employee at work, so you're having to have a disciplinary hearing with an employee and they've walked through the door, being able to work through these 4 things and reassure them from the beginning, we're on the same side. This is exactly what's going to happen. We're going to work this through together. You're going to be able to say what you want to say and your side will be heard. All of those things just increases the level of safety, even in very difficult conversations. So we're going to start at the beginning of the consultation, and you will see the book that I'm using, particularly for the structure of this, which was the Bible of consultation books when I was doing my family medicine training, which I did in the UK. And this is written by Roger Neighbour, who was he was the president of the general practice, the Royal College of General Practitioners when I was qualifying. And this book, The Inner Consultation, was sort of the Bible of every family physician. And it's a lovely book. So if you also like reading up about things, it's definitely worthwhile getting. And it's very practical in how you craft the consultation to be more patient-centered. We're going to start off with the first of these things. He's got 5 things that he described, which is connecting with your patient. Now, before your patients even walked in the room, you can already do some powerful stuff with the way you arrange your rooms. Now, some of you might already be very aware of this, but I teach medical students from WUSU, and I'm surprised quite often how many of them are not always aware of a closed consultation room arrangement and an open consultation room arrangement. And what I have noticed is when I go and work in different clinics and hospital, that when most people set up the room, it's usually closed consultation. And my favorite habit is rearranging the rooms. And what we want to do when we organize our room is we want to create our patient to feel that we are on equal power, and we want to make our patient feel that we're on the same side. And we can do this through the way we physically arrange our room. So just some examples of a closed consultation style. So you can see here, the doctor is sitting in the back, there's the window behind him, and then the patients will sit there, and there's a desk in the way there, which is a barrier between the patient and the doctor. So that barrier is already what we call enclosed. Here's another example. I'm not even sure where the window is in the story, but you can see, well, there's the computer. So there's probably the person sitting. Here's probably the patient. Both of those rooms from an infection control point of view is also not ideal. You want your patient closer to the window. So it becomes interesting when you move around. The other thing that sometimes happens, and this, my financial advisor does this, he's got one of those large, beautiful desks, you know, with the big, thick legs. And he sits on one of these big, large swivel chairs. And then you sit across from him on the decks on one of those little chairs with no arms. And he's this huge man as well. So you feel like this little person listening to the great financial advisor. I'm actually at the point where I think I might have to change my financial advisor. So you might also have that there's a much bigger chair for the doctor than there is for the patient. So what would an open consultation room look like? And when I arrange my rooms, partly it's how to make my patient feel more comfortable, but it's also about infection control. And so this is a nice example of a little room, and you obviously need a place to write, because we do have to write rather a lot. And what you do is your patient's sitting over here, and here you're sitting, and the space between yourself and your patient is open. So you can arrange the room in such a way where you're able to write, but you are still able to look towards your patient. You'll see the windows over there, the door's probably back here, so there's a draft that goes between you and the patient out the window. That's just a nice TV touch. And this is another example of somebody's actually designed a consulting room. And you can see here as well, there's the doctor sitting, there's the patient, there's the window. So again, the draft will go, there we go. Between you and the patient. In this one, they've also used big chair and small chair, but if the chairs are on the same level, that's not a problem. You don't want to have this position where you're towering over your patient. So you already arrange your room before your patient comes in. Now your patient comes into the room, and as I've mentioned, the coaching habit looks at how we ask questions. The whole thing is about asking clever questions. And he got what he calls the kickstart question. Now, this is not actually so much a medical question, so I'm going to show you variations of this. But this is a good question to know anyway, if you, for example, have been called into a meeting to see somebody, or you've got a mentee or a doctor wants to speak to you, or a patient calls you over because they want to speak to you about something. And the magic question is, what is on your mind? It's quite an English question. And with that, I mean is that it makes more sense with people who speak English well, what we mean by that. Because we're not asking, what are you thinking? We are asking what at the moment sits within your consciousness. What is this thing that is at the foremost of your mind? In medical terms, we quite like the question, what can I assist you with? And you can see these are very open questions, and there are questions that puts into importance what is going on for the patient. The closer question that I like to use is interestingly, it works better in Xhosa than it does in English. So it literally means, do you have a problem today, or what problem is present today? But in the Xhosa culture, this is very acceptable to ask what is the problems, where in English one normally doesn't do it quite so directly. But all of these have the same purpose. We are opening the floor for our patient to start speaking and telling us what has been going on in their minds, what problems have brought them here while they've been sitting in that waiting room. And then the golden minute is one of those key concepts that's actually been very thoroughly researched. So there is lots of evidence on the importance of the golden minute. For those of you who don't know what the golden minute is, the idea is that when your patients start talking, you shut up. You don't say anything for at least 60 seconds. And sometimes it needs to be a bit longer depending on how much your patient speaks. Now you might think, well, that doesn't sound, very much. Surely I'm not interrupting. But what they have found when they videoed lots of doctors tend to interrupt on average within 18 seconds and quite often even earlier. So what happens is the patient goes, well, doc, I've got this cough. Oh, when did the cough start? Are you coughing up blood? Do you have chest pain? Are you sweating at night? Have you lost any weight? So what happens is the patient starts off, and usually, remember, your patient's been a bit overwhelmed. He's got all this stuff going on in his head. The first thing he says might not even be the most important complaint. He's warming up. He's starting to try and build up his story of what he wants to tell you. And as soon as we interrupt, we're going on the doctor-centered agenda. I'm going to diagnose his cough. I'm going to figure out if he's got TB, and I'm going to put him on the right treatment. This ability to stay quiet until your patient is finished is probably, if you've got to pick anything, if you're going to pick one thing you want to do, I would recommend you do this one, because this is where they have actually done evidence to show what difference it makes. And there's several advantages. The big thing is that you get less of what they call the doorknob phenomenon. So what happens is your patient comes in, you interrupt them, you go down this whole thing, you come up with a script, you give them the prescription, and the patient gets up, and as they get to the door, they go, doctor, there was just one thing out, and now the real story comes out, and suddenly you're starting all over again. Definitely, they have shown that if you just listened well in the first minute, there's much higher patient satisfaction, because if you know why the patient has come, there's a much bigger chance you're actually going to meet their agenda. And very importantly, there's less litigation if you're able to listen in that. There's less of a chance that you're going to miss something. But because you are actually figuring out what's going on for your patient, you're building a better relationship. And strangely enough, litigation has not got to do with how many mistakes you make, but whether your patients like you. The other thing that's interesting is that there's always been a concern, and what doctors find difficult is they're worried about time. So you're sitting in a busy OPD, there's a queue out the door, and you're already having these visions of having to get through your OPD and sitting there quietly while the patient's mentioning that he's coughing blood and, has a bump on this toe, and all of these problems you already want to start solving, and you're worried that you need to start getting on with the agenda. What they have shown that by listening properly in that first little bit, you will not end up having much longer consultations. And if you do have a slightly longer consultation, it's because you're dealing with stuff that actually really needs to be dealt with. So you're not necessarily going to be wasting time, and you're going to be missing less things, because your consultations are going to become more efficient. A minute is not that much. So first, start trying to be quiet when your patient starts speaking. And this is why I'm saying I'm not always patient-centered. In a TB hospital, we go down that TB track very quickly when your patient comes in with their cough. So now the patient is talk. And the next big masterclass coaching question, also from the coaching habit, is the OR question. And it's an abbreviation, and it stands for, and what else? So not only are you going to be patient while your patient explains, you're going to ask him, okay, great. And what else have you thought about? And what else might be happening? And any other symptoms that you have? Patient goes and maybe comes up with, great, and what else? So you're going to ask that question until the patient has run out of things to say. And don't worry, it's not going to take nearly as long as it sounds. And of course, you're going to be making notes. And what quite often happens, by the way the patient's describing all the things that they want to talk about, you're going to start getting an idea of their health beliefs, how they think about their illness, and how they think of what's going on. So what you want to do is, when you've now had all this information and now you're ready to start going and unpacking all of this, just before you unpack, you're going to do a quick summary. So you're going to say to your patient, okay, great. I'm going to what I hear you saying is that you've noticed that you've been coughing a lot, but you've also been worried because there were specks of blood the other day when you looked at your tissue, and you've been getting tummy aches, and you're very worried about your teenage daughter at the moment, and you sort of run through all the different things they've brought up. And quite often the patient will then either correct you, or will add something if there's something that you've left out. And now, once you've done your little summary, once you've done your little introduction, and literally this will take less than 4 or 5 minutes quite often, now you can start clarifying. So you can summarize and you can say, I just wanted to ask a few more questions about the cough. And it's interesting this that you're mentioning, can I ask some more things about that? So you can start building up your more in detail normal history that you would normally be taking. So this first part is the patient-centered part. It's purely patient-centered and it's simple, and give it its time and it will give you great benefits later on. Well, when we now get to the point where I now have to assess what I think's going on, that's actually a very doctor-centered part of the consultation. You're now the one that has to figure it all out and unpack it all. And you are now the expert at work, and very important to still do your examination. And there's two reasons. The one reason is obviously you need to do a targeted examination to now look at whatever the patient has brought to come up with a good diagnosis. We all know that. I'm quite happy that examinations can be targeted. It's not practical to do a full examination on every single patient. But your examination will probably be much better informed because you know all the little things that the patient is worrying about. There's another reason to examine well. And that is that it actually increases patient compliance. And this is one of these things that's also been shown in studies to be very effective. So the problem is your patient has been thinking and worrying about something. And now the patient has come up and is very concerned. And quite often when the patient explains to you what they're concerned about, you can already see from here, oh, it's fine, it's not a problem. I remember specifically a patient who, this was when I was a locum in general practice, who presented with a bite. So she had a bite on her abdomen. It was 2 days old, it's a little bit pussy, and she had a headache. And she came in convinced that she had tick bite fever because her husband had a similar bite a week or two before, and he went to his GP and he got doxycycline for tick bite fever. So she was here for her doxycycline script. And already just from the description, it was only 2 days after the bite, there'd never been a tick in sight. And she did not have fever. None of it fitted in with tick bite fever. It was quite clear that it was not tick bite fever. But it's important to have, even if it's just a 1-minute examination, to properly look at the bite, maybe just, check for neck stiffness, look in the eyes with the light, basic little bits of examination. You might pick up something weird. That sometimes happens. But just that taking a little bit of time to actually examine your patient makes your patient feel like, okay, they've taken me seriously. She's really thought about this. And so now when you get to the point where you're going to explain to her that actually this is not tick bite fever, it might just be a spider bite, she's not going to need doxycycline, and this is what's going to happen, it's much more likely that she's going to believe what you say and she's actually going to engage. Okay, that's great, I'm reassured. If you go in too quickly and don't even examine and eyeball that bite from me and go, no, that's probably just a spider bite, yes, some fluke, it's a bit of fustian ointment or whatever. Your problem is that the patient might leave and not sure, maybe does the doctor know what he's talking about? She's not sure that this doctor has actually looked at it properly, and either go and see another doctor or go and Google it and come up with a completely new diagnosis. So you've got your physical assessment, and that we all know. So I don't need to spend too much time on it, just that it's important. But the other part of the assessment, and this is a tricky bit, is trying to figure out what's going on with your patient who is non-compliant. So most of the times when our patient comes in, we're usually on the same track. They've got symptoms they need solving. We want to solve their symptoms, and we're sort of working together to get there. But the hard consultations is those patients who are poorly adherent to treatment, whether it's diabetic or HIV or TB or missed follow-ups or antenatal or whatever it is. They've not been coming for their appointments, or they've not been taking their treatment. And now part of your assessment is trying to figure out what's going on. What is the actual problem here? So my next favorite book is called The Influencer by Joseph Grenny. A lot of his videos and work is also used by the Health Quality Improvement Institute in America. And he's got some great videos in terms of changing health behavior in hospitals. He's got a lovely one on hand washing, for example. And he looks at both at how you identify the level of the problem and also different tips and tricks on how you influence change. So very worthwhile looking at. I see my internet connection is unstable. Okay. So there's two different things that you want to think about when your patient is not taking the treatment. either my patient's not able to. So there's something that is interfering, obstructing his ability to actually comply with the instructions that we've decided on. Or my patient is not motivated to take the treatment. And there are different levels of these, which I'm going to show you in the next slide. But you manage those two things very different. If it's a motivation issue, how you have to work with how you help to get the patient motivated, and an ability issue, you actually have to come up with practical solutions to solve that. So Joseph Grenny created this 6 areas of influence. You can use it both to identify where the issue is, but you can also use it when you try and influence change. So the idea is you have to influence on all 6 levels. So he looks at motivation and ability, and he looks at 3 different levels. So the first level is on a personal level. So am I personally motivated to take my treatment? If this is important to me? And what is my ability to take treatment? Am I able to open the bottle? If I'm giving treatment to a child, am I able to read the instructions? Do I have a knowledge and understanding of how long I'm going to take this treatment for? So those are 2 different things, but it happens on a personal level. Now, personal motivation does not mean the patient just goes, I don't feel like taking treatment. What happens more often is that there's more important things going on in their life than their health. There's more complicated things going on in their life than their health. And so sometimes they just don't have enough motivation. They're just too overwhelmed with other things. But a very strong factor in whether people are able to take medication is what's happening in the families around them. So social motivation has to do with how much family and community support there is. And social ability is how much they're being enabled or disabled by somebody. So we all know of women who, for example, will take their contraception in secret without their partner knowing. So that interferes with their ability to take their treatment because they have to hide it, for example, from a partner. And then there's on a structural level. So these are practical things. So on an ability level, if they don't have transport to get to the hospital, that's an issue. If they don't have access to a clinic, that's an issue. If they can't get time off work, those are structural barriers to being able to take their treatment. But there's also ways that you can structurally motivate somebody. So for example, creating a fixed dose combination of 1 tablet a day is actually a structural thing to make it more easier and motivate people to actually take their treatment rather than having a handful of tablets. I'm not going to cover much more detail in this. It's more about creating an awareness when you're listening to your patient and you're asking them, you're going to try and get to the bottom of this question. And the magic question, question number 3 from our masterclass coaching is called the focus question. Remember, you've got lots of information from your patient now. You've been trying to find out what's going on with them. You're going to ask questions around how they're managing in terms of taking their treatment. But now you can start saying, and the question here, you have to almost do it exactly like this. What is the real challenge here for you? So for you in this particular situation, what is your biggest problem? What is your real challenge? And part of that is now you can start asking them at this stage, hopefully you've built up enough a relationship where you can say to them, you know, I've got some thoughts, but what do you think is causing your symptoms? What do you think is causing your problem? So if I asked my guy with a sore foot that right at the beginning, it would have saved us a lot of time and frustration with him sitting in hospital when he was not getting the most appropriate care because I hadn't asked him this simple question. And patients don't often offer that because they do think we'll judge them for the reasons that they think is there. And quite often we have to ask that what else quite a few times before we actually get to the bottom of what we think is causing their symptoms or their problem. Great, we're getting to part 3. We're doing very well. Any questions at this point